Dr. Vivienne Nathanson was, until very recently, Senior Director at the British Medical Association. Indeed, for many of us, she was the best of the British Medical Association. For much of her time at the association, Vivienne's been responsible for the health of the public, ethics and human rights. And she's worked closely with a whole series of BMA presidents over that time to see her work come into action. Right now, she's working with Michael Marmot and his Institute of Health Equity, and also with the International Committee of the Red Cross, for whom she regularly lectures and writes. She's also the Principal Advisor on Health to the World Medical Association. She comes here today with enormous experience and knowledge, and I'm very much looking forward to what she has to say. Please welcome her.
Thank you. It's a great pleasure to be here. And I thought that as we're getting on late in the morning, I would reflect on some of the actions different groups that I'm involved in are taking about some of the threats that we've heard. And Ira's challenge and call to action I thought was great, because I share his view that we have the chance to change the world. I think the problem for young people is that we're also asking them to change the world in terms of climate change as well, and they didn't cause that either. But you know, then that's the lot, isn't it, of being young? At least you've got time to do some of these things. One of the things that I find really interesting is how do we move from what the ICRC, the International Red Cross, are calling at the moment a community of concern to a community of action. And they're using that phrase in relation to their project on healthcare in danger, which is this project to identify and to stop attacks on healthcare workers, the institutions in which they work, and most importantly, their patients. And that we've already heard from José just how common that is around the world today. So this started for the Red Cross looking at 18,000 consecutive patients brought into their emergency hospitals and just looking at the cause of injury and what happened to them. But then they started looking at what actually does that lead to in terms of when they're in the hospital, you know, what are the numbers of attacks. But this issue of a community of action is a really interesting one. We're all very good at saying, I am frightened of nuclear war and I think it's awful, but it's somebody else who's going to make the difference. And the question is, how do we add together tiny efforts, which all of us are capable of making, to make something that's much bigger, much more substantial? And that's some of the things that I've been doing, particularly with the World Medical Association. I also want to mention that the thing about healthcare workers today is that we have a holistic view of health. We don't think about just, is the patient's biochemistry and anatomy normal? We think about, are they flourishing in society? Are they socially, psychologically and physically well? And that obviously takes us in the terms that Andy was talking about to looking at the environment in which people live, whether the climate's right, whether the environmental issues and so on are good, bad or indifferent in general terms. But one of the things then is, how can we move to reflect that back to governments? Because governments quite often think of health, it seems to me, in a very simplistic way. I remember going to talk to a shadow Secretary of State and to try and lobby him on a major public health improvement that he could make, and saying, can I brief you on this issue? To which the answer was, I've been Shadow Secretary of State for a number of years, I know everything about health. That very morning I'd been speaking to Professor Sir Michael Marmot, probably the leading epidemiologist, or certainly one of them in the world, who had said to me, the wonderful thing about this work is you learn new things every day. Who did I believe? Yes, Michael, clearly. But I think that the key to me is we have to find ways of getting politicians to listen to the message. And that takes me back to one of the fundamentals, that healthcare workers are really good at using evidence. We've heard that today. And we need to use that evidence to persuade governments of doing the things that we think are important to health. And some of those are little things, relatively little, such as, banning smoking in cars when children are present. I remember when the BMA produced its report on that, on the Today programme, the minister against me said, nobody would support this, though, this would be politically impossible, the public would think it was mad. That was on the Today programme. That same day, at the lunchtime programme on Radio 4, he said, this is a very interesting concept. We're going to read the report. By the PM programme, when questioned by Eddie Mair, he said, this is a brilliant idea. The government is going to legislate. It only took a day. I mean, when you think of some of the campaigns that we run and how long they take, but it's about the quality of evidence, and the biggest thing that we have to do is get the public on side. And so the number one thing is making what we say relevant to them. If we start talking about things in pure science, it doesn't make any sense. But when we put the person in the centre of it, and very often it's the person, not a patient, it's the ordinary member of the population, then they begin to get it. So when we talk, as we've just heard Ira talking about the fact that people will starve, millions, billions of people worldwide, that makes an enormous difference because people can actually see that nuclear warfare is relevant to them. So we have to make things relevant. And whether you're doing that about a relatively small national or even regional public health move, or whether you're talking about it in bigger terms, it's the same activity. We have to also recognise something else, that in a lot of the work that we do, we see the people who are already most at risk, and this is absolutely true of all warfare. Warfare is not fought on foreign fields anymore, it's fought around the places in which people live. So the ordinary civilian is often affected. But it's not the most ordinary, it's the most ordinary civilian in the sense that the best off are often able to get themselves out of there. And we have to recognise as well that the people who are going to be very heavily affected by conflict will be the poorest. They've already got all that overload of all the adverse health issues. They're going to have grown up in poverty, they're going to have difficulty with food and water and housing and so on. So when we take away more by the conflict, they are going to have even more difficulty in recovering. If they happen to be the very well educated, fairly well off, they are probably going to have the facility to move themselves or to help themselves to recover. So a lot of the work that I'm doing with Michael on social determinants of health, on health equity, is incredibly relevant within conflict situations, because disproportionately the people at the bottom of all those graphs are going to be the ones affected. I think the other thing that we can say is we have to recognise that outside this room, not all healthcare workers are pacifists. But we can still get them on side, because the point that all healthcare workers would share is that it is absolutely unacceptable that when there is a conflict, that there is no plan for what you do when the conflict is over. Why was there no plan for building decent power systems in Iraq after the invasion? Why was there no plan for reinstituting the water supplies? The things that would have made life easier for the population who'd had an incredibly hard time before the war and then during it. And that's something that we should be concentrating on, the public health measures that can be taken, and that is a unifying voice. There are other things that we can do in relation to that. One of Michael Marmot's great truths is there's no such thing as a natural disaster. And you go, what? What about earthquakes? Well, his point is that it isn't the earthquake that causes the damage. I mean, yes, it is a proximal cause, but it's the fact that you don't prepare for it. So why is it that two earthquakes not very far not very far apart in time, in Haiti and in Chile, of this, and where the Chilean earthquake was of a much greater magnitude, I mean hundreds of times the magnitude, and where a handful of people died, as opposed to Haiti, where there were hundreds of thousands of injured and dead. And the answer is preparation. So again, it's back to public health issues. We can do a lot about that. When we start talking about prevention of public health disasters, it allows us to get the ear of people so we can talk about the man-made disasters that are armed conflict, or I don't know what you actually call the kind of nuclear strikes that Ira was talking about that. I mean, I suppose it is an armed conflict, although it does increasingly sound like nobody would bother to declare war, they would just bomb someone. So there are a lot of things there that we can do, and we, at the WMA, we're passing a lot of resolutions on this, and we're now trying to get people to take action. And part of that is to teach medical associations advocacy and to get them to go out and join up with their nursing associations and their dental associations and their medical student associations and everybody else in the healthcare field to advocate together. I would just say that we have a number of toolkits and things like that that we're producing for this. We've just produced, it will go on the website this week, a toolkit for healthcare workers in armed conflict on the ethical issues that they will face. I commend it to anyone who's working in that area. MSF helped us with the thinking about what were the situations. Because one of the things that comes into it is how governments have responsibilities too, and it gives them the tools to go to governments and to get them to provide the proper safety. And we're just beginning producing a second toolkit, which is for other situations of violence, civil unrest, those sorts of things. So again, the ethical issues. So we'll help for our Turkish colleagues, for example, where doctors are being obstructed from helping people at the times of protests and indeed the recent bombing in Istanbul. So those are the things that we're doing. I do think the most important of all is that we actually start to work together collectively. And let's actually stop thinking, I belong to organisation A and it's doing, and saying, how can I get all these organisations to work together? Because together, we are probably invincible. Thank you.